Hi, my name is Catherine Moore. I'm a foster and adoptive mom and a family medicine doctor at Affinia Healthcare in St. Louis, Missouri. And today I'm going to be talking to you about care of families affected by foster care. I have no financial disclosures. However, I do want to point out early on that when it comes to my position within foster care, I'm a physician, I'm a foster parent, and I'm a Caucasian, which each individually place me at a position of privilege within foster care system. When creating your clinic policy, it is important to center the voices of foster youth and families who have had children removed from their care. Seek out their voices. Well, I have no other disclosures, but I do want to start with a confession. I didn't become a foster parent from a necessarily pure and holy place. As a young medical student and resident, I was overwhelmed by the trauma and abuse my patients faced. Many days I would search scripture and I would just cry. I read, God, that you're near to the oppressed, that you take up the cause of the widow and draw near to the fatherless. But I'm just not sure if you're holding up your end of the promise. While I'm not sure I ever spoke it out loud, I may have been wondering if I could do a better job than him. When I was an intern, I took care of a little girl on the pediatric floors who was literally in the hospital only because there were no foster families available to manage her insulin regimen. She was hospitalized for 2 whole months, and at the end of my rotation, she was transferred to a group home in the Chicagoland area, far from her St. Louis home, just so that there would be nurses present to manage her insulin. Every night that month, I would cry and I'd try to brainstorm ways to bring her home with us. And at the end of the month, God spoke to my heart and said, not this one, but there will be another child who will need you to step in and care for them. A few years later, at the beginning of my chief year of residency, we welcomed a little boy into our home. He could barely walk and barely talk, despite being 3. One night, I knelt beside his bed as he said his evening prayers, and he prayed, "Thanks, God, for scooting a little closer." Yes, let's approach this presentation today in light of that we truly serve a God who scoots a little closer to the fatherless, to the oppressed, to the abused and abandoned. And as we draw near to foster children and those affected by foster care, we are in the presence of the Almighty God. I'd like to start with a really basic definition, and I'm going to actually read it straight off the slide, of what the goal of foster care is. According to the Missouri Department of Social Services, the goal of the child welfare system is to protect children and provide services to help them stay at home. When the court decides that staying at home is not in the best interest of the child, they may be placed in out-of-home foster care, also known as foster care. They may be placed in out-of-home care, also known as foster care. Foster families provide safe and caring temporary homes for children while their family works towards their goals and reunification. Now you might be thinking to yourself, Catherine, I'm not a social worker and I'm not a foster parent, so what can I do to help? Well, I'm glad you asked. Many of us in this room are medical providers, and so some of these statistics might really resonate deeply with you. So for children entering foster care, about 80% are coming in with documented history of neglect or abuse. 50% have chronic physical problems, 10% are medically fragile or complex, and about 40% enter foster care with oral health needs. About 80% come into foster care with significant mental health needs, and over 80% have been exposed to significant violence. About 16% of children in foster care have fetal alcohol syndrome, and 60% of children under 5 years of age have developmental delays. And over 40% of children of school age have educational delays. Early childhood trauma can lead to poor emotional regulation, impulsivity, aggression, attention, and attachment problems. And as a result, children in foster care are prescribed psychotropics about 3 times more often than their Medicaid child peers. Now, I don't know about you, but those sound like problems that we know how to help. We can step in. This is within our training and our resource management. However, there are barriers to providing great care to kids in foster care. It can be time consuming. Their health care records can be incomplete and fractured. You might have questions about consent, who to ask permission for what. And you may have inadequate resources, sometimes being limited by state insurance itself. However, there are a few things that make up a foster care friendly office. That might be one that offers a medical home model, an office that's able to identify community resources, is able to stay organized and maintain appropriate side and consent forms, has consistent EHR processes, is willing and able to communicate with caseworkers and foster parents, an office that's educated on the effects of childhood trauma and adversity on childhood health, and is able to reframe child behavior in the context of trauma and toxic stress. If you're anything like me, you're always looking for new evidence or better evidence or thorough evidence to help provide care in your clinic. Thankfully, the American Academy of Pediatrics published Fostering Health: Standards of Care for Children in Foster Care back in 2005. For us, Missouri recognizes these as the official guidelines for the care of the foster child, and most other states do as well. Here are a few highlights of those recommendations. A child must be seen within 24 hours of entering care. A child requires 3 healthcare visits within the first 3 months. Medical records are to be incorporated into the Permanent Children's Division record. An accelerated well child visit is recommended based off of age. So from 0 to 6 months, they're recommended every month. From 6 to 24 months, they're recommended every 3 months. And greater than 2 years of age, they're recommended every 6 months. Now, you might recognize that that's about twice as often as we normally would see a well child in office. Additional visits are also recommended with transition of caregivers, for example, if a child returns to their biological family or changes foster care placements. And then when possible, the AAP recommends that we have longer office visits to accommodate the child's needs. So let's touch a little bit more about those 3 visits that are recommended within the first 3 months that a child's in care: the initial health assessment, the comprehensive evaluation, and the follow-up health assessment. The initial medical screen is intended to identify health conditions that require prompt medical attention, such as acute or chronic diseases requiring therapy like asthma or diabetes or seizure disorders, signs of abuse or neglect, signs of infection or infectious diseases, and any hygiene or nutritional problems for older kids, pregnancy, and things like that. Another goal of this visit is to identify health conditions that should be considered in making placement decisions. So an example of this in our case was there was a little girl that came into care, and at her initial health screening visit, she was noted to have an upper respiratory infection. Pretty common to have a lot of boogers in a young child. However, the foster mom in this case was undergoing chemotherapy, and so it was decided at that initial health visit that it would probably be best for the little girl to be in a different placement. So our family was called, and she joined our family for a while. The foster family at this point in time probably doesn't have a ton of information about the child, as it's usually within 24 to 72 hours of them entering care. But the provider should review any available health information, get a brief trauma history, whatever's known, complete a review of symptoms, do a basic symptom targeted exam, look for obvious signs of child abuse, do a quick developmental screen. Again, might not be able to do much at this visit. And then screen for mental health red flags like suicidal ideation, homicidal ideation, violent behaviors, and any obvious signs of trauma. For adolescents, you may want to include a pregnancy test or STI testing. At the close of this visit, you would want to initiate any appropriate treatments and place any referrals that you've identified to be helpful. Communicate with the caseworker. Find out from the foster parent if they know what's best to do that, whether it's giving them a call, faxing them an after visit summary, or a complete office visit. Again, remember, we're trying to incorporate all of the medical records into the child's children's division record to the best of our ability. And then provide any anticipatory guidance, especially related to foster care and a traumatized child. The comprehensive visit is just as it sounds. It's supposed to be a more comprehensive, detailed visit, and the timing should be at the end of that first month that a child's in care. The goal is to review any available health information that's been able to be gleaned in the last 30 days, to identify acute and chronic health conditions, to identify developmental and mental health conditions, to do a more thorough trauma assessment, and to develop an individualized treatment plan for the time that this child's in foster care. In St. Louis, these visits are predominantly done by our 2 children's hospitals. Fostering Healthy Children Clinic at Cardinal Glennon cares for children ages 0 to 12, and the Spot Coach Clinic at Washington University cares for kids ages 13 to 17. So a few notes about gathering records. This can be pretty tricky and requires some planning. So first things first, just call the caseworker, see what they have found out about this child and their medical history. A big way that we find out a kid's medical history here is we use the Medicaid claims database to see who has billed for what, and hopefully do some tracing of the child's steps to find out which clinics they've been to or what vaccines they've received. Sometimes calling the school is helpful to get a vaccine record. If available or accessible, hospital EMRs can be helpful. Like I said, here in St. Louis, we get some help for this initial data collecting from Cardinal Glennon and the Spot Clinic. At medical visits, oftentimes the biological family, if it's safe and helpful, they're invited to be a part of the visit. And so if they are present, please attempt to learn the child's past medical history and family history, because that can be super valuable for the child to have in their file. So the components of the comprehensive health exam are to review any of that available health information that hopefully we've been able to glean in advance, including their trauma history, and a lot of screenings. Age-appropriate developmental screens, dental screens, hearing and vision screens, child abuse and neglect screens, review their school performance up to this date, and then do an immunization review. Now, the American Academy of Pediatrics recommends that if you're not able to get any vaccine records on a child after doing your due diligence, that to assume they're vaccine naive and initiate the catch-up vaccine schedule. At this point, you'd want to do a review of symptoms and a complete physical exam, including a genital exam. For adolescents, you'd want to add in family planning and sexual safety counseling. The AAP recommends that on all children entering foster care, we complete an HIV, hepatitis B, and hepatitis C, and in all children under the age of 6, to complete a lead and a hemoglobin and hematocrit. And for all other cases, consider any other labs as appropriate. At the end of the comprehensive health assessment, you would again do appropriate treatment and referral. You'd communicate with the caseworker. You'd do anticipatory guidance, especially around parenting the traumatized child, and you would schedule the 90-day follow-up. So for the follow-up assessment, like I said, we're going to do that within 90 days of the child entering care. You're going to continue to identify any acute or chronic health conditions, but at this visit, you're going to assess for ongoing stressors. To the best of your ability, pay attention to the foster parent and child interaction or the child and biological parent interaction, depending on who's present, and assess for goodness of fit. Again, if you're documenting, please document objective behavior to the best of your ability. You're going to continue to work on updating immunizations as necessary, continue to provide health education, and review findings from the developmental and mental health evaluations that were done before. Now, many kids have to change schools, even though we try really hard not to, so assess school adaptation and performance since the last visit. And then you're going to update and reinforce the treatment plan. Hopefully by this time you've also gotten some of those referrals and reports back that you ordered at the last visit, and you can review those with the foster parent and foster child and review and update any of the treatment plan as necessary. Again, you're noting some common themes with these visits. Continue to do anticipatory guidance, continue to communicate with the caseworker, and schedule follow-up appointments as indicated based off of the age and the child's needs. At all visits, We encourage you to look for signs of abuse or neglect, as we know that kids in foster care can sometimes be at risk of abuse in their foster homes. Some of these include poor weight gain, lack of warmth, frequent missed or canceled appointments, and failure to comply with physician provider recommendations. At all visits, do age-appropriate screening that we'd normally do with kids, like hearing and vision, lead, H&H, height and weight. Complete skin evaluations as indicated, follow up on education, and doing your own educating and updating immunizations. Some encounters may be necessary to complete genital and anal evaluations, especially if the child's preverbal, and at some visits it might be necessary to do STD testing. Just to touch on a few issues that we've noticed come up, the electronic health record can have some unique difficulties for a family affected by foster care, so even starting from registration. So what to put down as the child's address. So in most cases, the foster family's address is fine to put down as the child's address, as the foster family will want to have reminders of appointments and follow-up mailers as necessary. But there have been cases in which the biological family has had access to the foster family's address through the electronic health record, so just be careful and cognizant of that as a possibility. Also, please list the caseworker and foster care agency and the emergency contacts. Some cases, we've been asked to actually list the foster care agency's address as the child's address, depending on the situation. In the billing section, I encourage you to put the foster care agency in the state as the guarantor for the medical visit. That's what we've been encouraged to do here in Missouri. And if you have billing problems, the foster family might not always know the answers or how to problem solve, so it might just be best to go straight to the caseworker. If there's a transition of care and a foster family notifies you that a child's no longer in your care, please remove their information from the child's chart so that it's not in there when they go on to the next location. Obviously, you're not always notified, but do your best when you can. Or if a child has had parental rights removed from their biological family or family of origin, it may be in the child's best interest to make sure that the chart is completely removed of the biological family's information as far as addresses and phone numbers and things like that. One of our kiddos, we've had a lot of interesting things come up with having biological families' information still in the chart, even if we've tried to remove it. Patient portals, at least in our area, foster parents previously weren't able to be listed as the proxy to set up a patient portal for their foster child, but in the pandemic, a lot of that has changed with the necessity of telehealth appointments. So just know what the rules and recommendations are in your area. Billing is not all that different. However, you will want to make sure you include the ICD-10 code for child in welfare custody in your assessment. I have that listed on the slide. This will allow your well child visits to get covered at the accelerated rate. Otherwise, just use your normal established patient code or well child patient codes when you're doing your coding and billing. A few times I mentioned anticipatory guidance on the effects of trauma as we were going through this, and you might have found yourself wondering, I wonder what I could use. I mean, like, I don't really have anything like that in my standard after visit summary handouts. Luckily, the American Academy of Pediatrics thought of that. The Trauma Toolbox, which I linked on this slide, has a lot of great handouts, some of them more geared towards providers and medical staff, and some of them more geared towards parents or people parenting children in foster care. A helpful analogy for me when I'm trying to understand how trauma has affected our kids' development, especially our kids who are from hard places, is thinking about our kids as a giant puzzle. And each piece may have a different age despite the child's biological age. For example, one of our kids came to us about a year delayed in speech and gross and fine motor skills. However, their life experience and emotional intelligence was significantly higher than their age. So sometimes that's just what we have to work with. It's interesting to realize that every single moment that a foster family is in our office, the children are listening and paying attention to what we say. And in many cases, in most cases, these children love their family of origin. They don't really want to be in foster care. Or even if they've been harmed by their family of origin, they love them and long for things to be made right. So it's important to keep what we say, recognizing that. So I'm going to give you a list of things not to say, and each of these things are things that my husband or myself or other foster parents we know have had said to them within a medical office by medical professionals. They're so lucky to be with you. I bet their mom is a teenager or on drugs or a prostitute. Don't you want your own kids? Do you get to keep them? I'm sure you'll get pregnant with your own kid any day now. Which one is your real child? You foster children? I foster dogs. We're twins. How long until you find out if you get to adopt them? I could never be a foster parent because I would get too attached, etc. You may be wondering what happens to children when their time in foster care is over. Well, about 50% of them are able to return home. 6% are able to live with other relatives, and 10% find themselves in a guardianship situation. About 20% are adopted, and 10% age out or emancipated. In my current job, I take care of mostly adults. When I'm doing a social or trauma history and I find out that an adolescent or adult was formerly in foster care, this is really clinically important because former foster youth are at high risk of all of the following: human trafficking, homelessness, incarceration, substance use disorder, employment issues, and themselves having kids that are in the foster care system. Adults who are adoptees also have interesting considerations for us in clinical care. Many of them have incomplete medical records. They have poor knowledge of family medical history in many cases. They might have ongoing symptoms related to trauma. And studies have shown that adoptees are 2 to 6 times more likely to have a referral to a mental health provider and have increased risk of suicide with a 4 times higher risk of suicide attempt than their non-adopted peers. In my practice, I care for many people who are caregivers for children who are in foster care. And there are many ways that we can support them, including knowledge of medical requirements for care providers and just general knowledge of the system in your area. So for me, that's as simple as knowing how to find the physical form that foster parents and kinship providers have to have filled out every other year to be able to have kids in their care. Because sometimes you show up at your doctor's appointment and you forgot your physical form at home. And that can be incredibly frustrating, but we can put their mind at ease by just printing off that form for them and filling it out. Parenting children who have been in hard places or have been through trauma can be a little different than parenting your own biological children if they haven't been through trauma. And so there are a lot of great parenting resources available. My family personally has benefited from the Empowered to Connect curriculum through Texas Christian University, and there are many others available to support parents. Also be conscious of the possibility of secondary trauma and mental health needs by those caring for kids in foster care. And most importantly, provide all the empathy and support that you can. Now, there are a few folks on this list that I'd like to touch base a little bit more about. So biological parents. It is my joy to walk with parents as they are working their plan to get their kids safely back in their care. Now, how this how we can help with this is often by looking back at the reasons that the kids came into care in the first place. So about 36% of kids enter care due to parental substance use, 6% due to parental alcohol abuse, 9% due to inadequate housing, and 6% due to parental incarceration. So if you have a substance use treatment program, an MAT program, supporting parents through that. Maybe if you have social workers that have access to housing resources, or if you work with incarcerated or formerly incarcerated individuals, that could be a huge blessing to biological parents. I'm walking with a family right now, and I'm helping the dad with some mental health concerns that he has on his way to getting his kiddos back. And he recently had a court date that was long anticipated. He'd been doing really well, coming to visits with the kids, clean and sober for several months. And the judge told him, "Good job. You're doing so great. Come back in 120 days and we'll let you know what the next step is." He was crushed, absolutely heartbroken, and actually relapsed that night. And so, we've been there with him to help support him and say, you can do this. We're here to support you. Sometimes it can be helpful to communicate with a parent's caseworker or lawyer if they request, and if you've got proper documentation to ensure that that's okay. Kinship care is another area that a lot of my patients are affected by. About 33% of children in foster care are actually in kinship care with someone that they know, usually a biological relative, but often it can also be someone that's known, a close friend of the family. And this is actually really common in the African American population compared to other people groups. Kinship care is important because there's very good documentation that kids in kinship care experience fewer behavioral problems, fewer mental health disorders, and less placement disruptions. However, there's also research that suggests that relative caregivers are more likely to be single, poor, have less formal education, and have more chronic health conditions because of their advanced age. Relatives are also less likely to be aware of financial benefits. So not many know that they can receive benefits in some circumstances from the Temporary Assistance for Needy Families program. And over 50% of low-income kinship families don't receive SNAP or WIC or Medicaid health coverage. So when a family member comes into my office and I find out that they have had their grandchild or great nephew come into care in their home, I make sure to direct them to our WIC department and to our Medicaid enrollment department, just so that we can make sure that all of their needs are met. You might be wondering, Dr. Moore, we're ready to set up our clinic to serve families affected by foster care, but what more can we do? I'm so glad you asked. A very important thing that we can do is to leverage our privilege. So what this looks like for me is I prioritize trips to the state capitol to meet with my elected officials and make sure that they know that I'm here and eager to offer my expertise and experience on any legislation that comes across their desk affecting kids in care. They all have my cell phone numbers. They've yet to use them, but I prayerfully hope that they will someday. I was also recently appointed to sit on the Missouri Medicaid Show Me Healthy Kids Foster Care Stakeholder Advisory Council, and I will get to sit on the board that helps make decisions on insurance coverage for kids in foster care. That was a lot of information in 30 minutes. But in conclusion, I hope that this presentation gets you excited to meet with God in the care of families affected by foster care. The American Academy of Pediatrics has a lot of great resources to help you improve the care you provide. I encourage you to be thoughtful about everything from the registration process to the casual words you speak, as each and every touch point can have a huge impact on children and their families. I know this is a virtual presentation, but if you have any questions, I would encourage you to reach out to me. Here's my email on the board, and there are my beautiful children. 3 of them adopted through foster care. The two little ones just had their adoptions finalized in February and March, respectively, and we're getting ready to celebrate when I get home. Well, thank you so much for being with us tonight and for your commitment to families affected by foster care.